Originally from Hyderabad, born, brought up here, medical school in Sevagram, Maharashtra, then moved to United States. Been in Phoenix for about now 9 years, part of a large practice, a multidisciplinary practice, Ironwood Cancer Centers. We are by far the largest practice in the state of Arizona. Actively involved in clinical trials as well as research. Today I'm going to be talking about PNH,
Yes,
and I'm privileged and honored to be here to speak on this topic today. Diving right into it, PNH is a very rare but a fatal disease. The prevalence is about Prevalence is about 16 per million worldwide. Median age at diagnosis is in the early 30s. It's a very fatal disease. About 35% of the patients diagnosed with PNH die within 5 years of diagnosis, despite best supportive care. And that only keeps getting worse. Again, the pathophysiology in PNH is mutations in the PIG-A leading to decreased production or prevention of production of GPI anchors. That leads to GPI anchor deficient cells, leading to chronic uncontrolled complement activation, hemolysis, nitric oxide depletion, thrombosis, and end-stage organ damage. Again, another depiction of uncontrolled complement activation due to lack of natural inhibitors, CD55 and CD59, leading to uncontrolled complement activation and hemolysis, cell lysis, platelet activation, endothelial activation, and prothrombotic state. In a normal environment, the RBCs are protected from complement activation and by a shield of complement regulatory proteins. That is lacking in RBCs of a PNH cell. Hence, a normal cell is not affected, but a PNH cell gets affected and leading to hemolysis and obviously free hemoglobin and nitric oxide, leading to thrombosis to fatigue. Again, hemolysis in PNH is intravascular, leading to free hemoglobin, nitric oxide, as well as nitric oxide depletion. There is also platelet activation and aggregation, as well as leukocyte activation in intravascular hemolysis. Again, main morbidity and mortality in PNH is from pulmonary hypertension, chronic kidney disease, and last but not least, thrombosis, both arterial and venous. Chronic kidney disease is secondary to free hemoglobin as well as vaso-occlusion. Accounts for about 64% of patients with PNH have some form of chronic kidney disease. About 43% have stage 1, 2, 21% have stage 3 to 5. Pulmonary hypertension results from chronic complement activation as well as from vascular resistance, depletion of nitric oxide, and cardiac dysfunction. Pulmonary hypertension accounts for about 47% with PNH. Dyspnea is another common presentation in PNH. It accounts for 2/3 of the patients with dyspnea. However, 47% of patients have pulmonary hypertension. The other etiology or other reasons for dyspnea could be, again, one is pulmonary hypertension, second is pulmonary embolism, and severe anemia. Last but not least, thrombosis in PNH is a life-threatening condition. The common sites include intra-abdominal, lower extremities. However, uncommon sites are very common in this situation as well, as depicted here on an MR with a sagittal sinus thrombosis in a young patient. Thrombosis in patients with PNH may not be adequately managed with anticoagulation therapy alone. All patients with PNH are at risk for thrombosis, regardless of their clone size. Thromboembolism occurs in about 40% of the patients with PNH. However, it accounts for 2/3 mortality, up to 2/3 mortality in PNH-related deaths. Risks of thromboembolism increases with increasing or elevated hemolysis. For example, with just an elevated LDH of 1.5 times normal, the odds ratio goes up to 7. With abdominal or chest pain, goes up to almost 20. With hemoglobinuria and dyspnea, goes up to another 10. The relative risk of venous thromboembolism in PNH is 62-fold greater than that of the general population. That, when compared to the commonly known hypercoagulable factors, it's anywhere between 2 and 10-fold. Huge difference. Next, identification of high-risk patients with PNH. The ICCS and International PNH Interest Group. Any patients with hemoglobinuria, Coombs negative hemolytic anemia, unusual site thrombosis, aplastic anemia, and refractory myelodysplasia should be evaluated. In general, 3 categories. Hemolysis, or broadly 3 categories, hemolysis, bone marrow dysfunction, and unexplained thrombosis should be evaluated. Briefly, a case presentation. A 30-year-old female presents with fatigue, abdominal pain, femur hematuria, straightforward UTI, gets a prescription for UTI antibiotics, shows signs of improvement. However, patient continues to have persistent hematuria. Recurrently, periodically treated with antibiotics, does not get better. Urine dipstick is positive. Finally, a urine analysis is obtained, shows no red blood cells. Clinical diagnosis of hemoglobinuria, referred to a hematologist. Differential for hemoglobinuria are, again, PNH, autoimmune hemolytic anemia, microangiopathic hemolytic anemia, malaria, falciparum, drug-induced, and prosthetic heart valve. Hematologist does further testing. Hemoglobin mildly low, 11.2, LDH elevated, Coombs negative. Due to hemolysis and hemoglobinuria, a high sensitivity flow is obtained and patient is positive for PNH. Now switching gears to bone marrow dysfunction. Another case presentation, 23-year-old male with severe malaise and widespread petechiae. Further workup clearly has low counts. Severe anemia, 8.5 at 23. White cells low, platelets are low. LDH is normal, no evidence of hemolysis here. Clearly, the bone marrow biopsy is obtained due to severe pancytopenia and explained in a young patient. Bone marrow is hypocellular with a normal karyotype. Here, patients diagnosed with aplastic anemia are automatically prompt or should be evaluated for PNH. Patient has a very, very small clone. In this situation, there was no hemolysis, as there was a very small clone, not enough to cause hemolysis. The patient is continued on therapy for aplastic anemia. However, this patient needs to be monitored regularly, as the failing bone marrow can preferentially propagate the clone in PNH. The patient did have a small clone. And also in PNH, there's a 93% of the patients with PNH have some form of concomitant cytopenias, like anemia, pancytopenia, or other combinations. Last but not least, thrombosis. Briefly, a 30-year-old female who experienced multiple strokes over 3 years, had an extensive workup at multiple centers. She even had a full hypercoagulable panel, which was negative. Atrial fibrillation, myeloproliferative disorders were all ruled out. The patient, however, had obviously a atypical or unusual site thrombosis and had a very high LDH, as well as a severe anemia. The patient was referred to a hematologist on further workup. Hemoglobin is 7, LDH 1500, mild reticulocytosis. Again, due to the unusual site thrombosis as well as hemolysis, the patient has a peripheral blood flow cytometry run, and there's a significant amount of clone size and diagnosis of PNH. Again, in summary, thrombosis in PNH is life-threatening, can occur at any sites. Patients with PNH have a 62-fold increase over the general population of developing thrombosis. The first episode could be fatal. Patients may not be adequately treated with just anticoagulation alone if they have PNH. And testing for PNH is recommended for patients with thrombosis and evidence of hemolysis and cytopenias. There is a 7-time greater risk of thromboembolism in patients with elevated LDH due to hemolysis. The thrombosis risk is unrelated to the clone size. Less than 20, this is based off a South Korean registry. Less than 20, 20 to 50, or more than 50, doesn't matter. There was no significant difference. So no matter what the clone size, the patient could still be at high risk for thrombosis. Again, switching gear to briefly diagnostic testing procedures for PNH. Flow cytometry on the peripheral blood, simple. Evaluate for a granulocyte and at least one other cell line. Request quantitative results, as well as ensure there's more than one reagent at least for checking for PNH, that is CD. And this is a classic or depiction of a sample report. What should a report contain? It definitely a clone of PNH, detected or not. It should have all the cell lines listed, like the granulocytes. I'm sorry, the picture is not that good, but the granulocytes, the monocytes, and RBCs, and a good summary of what is going on by the pathologist or the lab to help us diagnose and manage. Again, few words about monitoring and follow-up. Patients with aplastic anemia and a very small clone size should be monitored annually. Stable disease in aggressive PNH should be monitored annually. Any change in clinical or hematologic parameters requires more frequent monitoring clearly.